Hi, I'm Ann Ellison, and today we are going to discuss laryngeal cancer and hypopharyngeal cancers, um, both of which are a group of head and neck cancers affecting 12,500 people per year, with an approximate 4,000 people per year dying from these cancers, which is a statistic from the Cleveland Clinic. Next slide for you so you can follow along. Residing in the state of Maine, we have seen an increase in all cancers. Maine has an aging population with cancer diagnoses increasing. I thought we should take a look at hypopharyngeal cancer and laryngeal field cancer. And part of this is laryngeal field cancers affect people over 55 who are tobacco users and heavy drinkers. I personally have seen the damages that this cancer has done with my own family. My grandmother developed laryngeal cancer in the late 80s, roughly 88, 89. And she had to go and see an otorhinolaryngologist for her diagnosis and then an oncologist for treatment. When she went to her primary physician, she had felt something odd in her throat, and she'd say like, not really sure what's going on here, doctor, but something doesn't quite feel right. But alas, we will discuss what each one of the words mean. So we have hypopharyngeal, which hypo means under. Pharyngeal is pertaining to the pharynx, which is actually the throat. And then we have laryngeal, pharyngeal, laryngeal. Larynx, which refers to the larynx or the voice box. O, which is a connecting vowel for this. Pharyngeal, again, pertaining to the pharynx or the throat. And an otorhinolaryngologist, auto meaning ear, rhino meaning nose, larynx meaning throat, ologist is one who studies. So this would be your ear, nose, and throat physician. And we're also going to look at too where these words come from and what their meanings are. So hypopharyngeal comes from Greek, and it refers to the supraglottis, the glottis, and the subglottis, which is in the throat behind the voice box. This is an area where a patient would feel some symptoms. For example, a lump in the throat, pain or difficulty swallowing, a sore throat, a cough that doesn't seem to improve, and interestingly enough, maybe some ear pain as well, because, it's a very small area in the body. And then we have laryngopharyngeal, which is also from Greek, and it again refers to the supraglottis, the glottis, the subglottis. And this is where the voice box is, just above the esophagus and the windpipe. Now, there will be some changes in the voice. There may be a hoarse voice or perhaps some laryngitis that doesn't seem to clear. And then again, we do have the otorhinolaryngologist, which is Neo-Latin, which is a Neo-Latin combining form from ancient Greek. It is a specialist, again, in the field of ear, nose, and throat. And this is the person who, again, who would probably be diagnosing the disease. Here we go, some slides again. Both hypopharyngeal cancer and laryngeal cancer will need to be diagnosed by a medical professional. You can't just have Aunt Molly make that decision. But a patient definitely should not wait to be seen. This is one which you should never put off for some of these symptoms, and that is dyspnea, which is shortness of breath, a globulous feeling, like you can't just seem to swallow whatever it is in the back of the throat, like something stuck back there. Hemotypsis, which is coughing up blood, which is, in my opinion, kind of serious. Stridor, which is, breathing that is noisy and high-pitched, kind of like that weird whistly type of thing going on there. And this type of cancer actually comes from malignant cells in the larynx. So, cells that are in the back of the throat. Um, and they will be doing some testing. So a doctor will first look in the mouth, look at the tongue, the gums, perhaps what they can, just real quick with a light to look at the back of the throat, like they would do, if you were just complaining of a sore throat. And then what's going to happen is they will palpate or feel the throat and see if they can feel anything in the throat itself, such as, like the lymph nodes. When you get a cold, your lymph nodes swell a little, and that's what doctors generally feel. And so, and when they do this, they're going to be looking at the potential of whether or not they have to do a biopsy. And there are two tools that they actually do use. This one here is an endoscopy. I don't know if you can see it there, but that's an endoscopy. And an endoscopy is actually used to look at the esophagus and the trachea. It's a tool similar, but not quite. Bear with me here. It is actually, trust me, the endoscope, they're going to put you out for this, because they don't want anyone getting stressed out. They want the patient as calm and relaxed as possible. And then we also have the laryngoscope. And this is to look at the back of the throat and to also be able to take some biopsies here. And this is one where I don't know if you've seen the different TV shows where they're like, oh, we've got to intubate someone, we've got to put a tube down their throat. This is something that they'd use that pushes the tongue out of the way so they can look down the throat a little bit better. And again, during these examinations, they're going to be removing some tissue. It's not the best thing in the world, but honestly, if they can figure out what type of cancer it is, if they can figure out what's going on, it may not be the best, but it will help at least some. And then the prognosis depends on the following. It depends, after they take these biopsies and stuff, then they're going to turn around and they'll probably order some radiological exams, such as a CT scan or a CAT scan, and perhaps an MRI or a PET scan, or a bone scan. And what they're going to do with the PET scan and the CT scan, and what they're going to do is that they're going to inject some either dye or some radiological material. Don't worry, the radiological material is really a small amount. They're just looking to see if you have tumors anyplace else within the body. Yes, Kitty. They're just going to be looking for tumors somewhere else in the body, because cancer is very insidious. It starts in one place. They think that they've found it in one. Then when they start looking, that's when they actually have to look and see if it has decided that it's going to metastasize someplace else, on the bones, in the lungs, perhaps in the spine. Some of these are pretty bad. If it goes from the lymph nodes into the blood, it will then present in other locations. And again, the prognosis does depend on the location and the size. So once they get through their radiological exams, then they will have to make other decisions as well. But it will be dependent on, again, like I said, the location or the size, the grade or stage. So, we count here like stage 1, stage 2, stage 3, stage 4. It also depends too on the person's sex and age. We did discuss earlier that men are more likely to develop this over the age of 55. It also depends too on the person's general health. Are they in good health, or do they have other chronic conditions that maybe will exacerbate this and make it more difficult to cover? There's also the question about family support. If the family is supportive, and you've got that family member who's going to say, what, I'm going to make certain that you get over this, that you feel better, then that's definitely someone who you want on your team. I know sometimes they can be a pain in the butt, but they're worth it. So once they get through those things, we can actually look at some of the causes of this. And some of the causes are sexually transmitted sexually transmitted infections such as HPV or human papillomavirus virus, which again, certain types, we know that can cause this type of cancer. There is a vaccine out that they give to children under the age of, I think it's 25, to prevent this cancer as well. Also, the use of tobacco products would obviously increase the chances of developing any forms of cancer. These two happen to be also in this grouping. So obviously, encouraging people to quit smoking or using tobacco products would be a good idea. Excessive use or abuse of alcohol. Again, if you think you're abusing alcohol, I'm sure that there are other facilities that you can go to get help. And again, men are at a higher risk for developing this, for developing hypopharyngeal and laryngopharyngeal cancers. Now, the treatment does depend on the following. Again, we're talking stage, if it's like stage 0, they call it in stew, which basically means it's not doing anything yet. So it's not too bad. Stage 1, it's really small. It's going to be easy to treat. Stage 2, it's a little bigger. It's still relatively easy to treat. By the time we get to stage 4, it's quite concerning. And the location, if it's just located in the throat or if it has spread to the body. And if it is in the throat, then we're going to be looking at, will we be able to keep that person's speech? Will they be able to eat and breathe as normal as possible? And again, are they willing to quit? If they smoke or drink excessively, are they willing to either stop the smoking and the alcohol abuse, or are they willing to curtail it just to, get better? I wouldn't recommend going back to the old habits because this is what led to this. Sometimes we have to be candid with people and say, this is it. And then there's also the question of whether or not it's going to recur. So this is where you go back routinely for checkups to see how it's going. And, the doctors don't want to call it in remission until you're 5 years past. They're not going to call you cured until you're after 5 years. They'll look and they'll say, oh, well, look, the medications and the treatments that we've done are working. But now the treatments that we have, most common is like radiation and chemotherapy and immunotherapies. But there's also surgeries too that will be done along with these. And the surgeries, again, will depend on how big and where the cancer is located. So the different types of surgery is a cordonectomy, which is removal of the cords only. So that does leave the person with their throat intact so they can breathe normally. You do have the supraglottic laryngectomy where they remove the supraglottis only. So they do still have their voice. They still are able to eat and breathe normally, but they would have to be more careful because of the structures within the throat. And then we have a hemolaryngectomy. I'm pretty sure I'm butchering this and I do apologize. Where it removes half the voice box. But it does still have that patient keep their ability to speak. We do have a partial laryngectomy, which also happens to save the voice. You have a laser surgery, which honestly, they call it a bloodless surgery because there's so little blood that's actually taken in this. And the laser beam's used as a knife and it's considered to be bloodless. Again, it removes some of the tissue. And generally this would be like in a stage 1 where there's not a lot of tissue that needs to be removed or a tumor that needs to be removed. It's going to be really small. It's going to be quick, hopefully not too painful. Hopefully a very short turnaround time and recovery. But we also have the total laryngectomy. And this one's actually pretty serious because it removes the voice box. And it removes the entire larynx of the voice box. It is where a stoma may be formed. A lot of times it's also involving the thyroid, so that will also be removed. And it's also called a tracheostomy. And then we also do have the thyroidectomy, which is the removal of part of all of the thyroid. Again, it does depend on how fast these two types of cancer are caught. Like I said, you're scratching, we're at home, we scratch our neck or something, and all of a sudden we're feeling something that feels like a pea in the back of our throat, and we call our doctor and say, hey doc, there's something wrong. And the doctor feels, and they're like, oh, well, this is a pea, and they're going to write in their report it's a 1 centimeter. The average layperson does not know typically how big 6 centimeters is, and 6 centimeters is actually the size of a chicken egg. And again, any one of these in stages 3 and 4 found in the throat would be very disheartening. It would be very disheartening for the patient. And again, some of these would be found within the body. I mean, obviously, I would hate to see the person who finds a stage in stage 3 or 4 and has a 10 centimeter or a grapefruit size growth within their throat. More than likely, that would be found within the body, perhaps on the bones, in the lungs, or maybe even growing on the spinal cord. Any one of these sizes is problematic because it first starts in the lymph nodes and it can spread through the body, through the blood system as well. And this is why, this is why you have the surgeries, you have the other treatments, the chemotherapy, the radiology, the radiotherapy. You can also, as a patient, you could also ask the doctor about whether or not you would be a good candidate for clinical trials. I do know that Dana-Farber is looking into some other alternative treatments that hopefully will help the patients heal a little bit faster. Just something to make it a little bit easier for people. And I know that you had asked about word usage, so here it is. And my word usage is a patient would see an otorhinolaryngologist, to diagnose either hypopharyngeal cancer or laryngeal cancers. And then my last slide here is a reference to all of the websites that I have used to get this information. I'm sorry, I did not put in the websites that I just Googled, the endoscope and the laryngeoscope. And I just happened to say, okay, well, show me images for those. All right, thank you. Have a great day.